Dr. Elliot, just had a quick question. Breast cancer does run in my family. My mother actually passed away 18 years ago of breast cancer, and I was just wondering if there's any special guidelines that I need to follow.
Well, actually, the Elliot Breast Center is pretty much based on the premise that there are people who are at higher risk of breast cancer who should be treated differently. And so we try to attract women into our breast center who have risk of breast cancer, who have family histories of breast cancer. We think we can provide them with more information, so we have genetic counseling resource who can actually sit down and talk to women about their risk and get some sort of a family perspective about not only what their personal risk is, but the rest of their family, what their risk is. And there are small numbers of women who actually have a chromosome abnormality that can be measured with a blood test that sets them apart. This is about 5% of all breast cancers. And these are women who actually have an 80% chance of having breast cancer in their lifetime. We screen these women differently. They're seen twice a year in the office, and they have a mammogram alternating with an MRI every 6 months. And that's routine screening for those group of people. They have hands-on evaluation. They have somebody looking at their mammograms right away and trying to come to a conclusion about their imaging before they walk out of the office. Obviously, that's the smaller patient population with breast cancer risk. The majority of people with family histories don't really have that chromosome defect, but really still should be followed in a structured setting with the best imaging equipment that's available to them, and hopefully a conclusion and education associated with their imaging so that, again, they can walk out the door at the end of their visit with an answer. There are programs that are available in clinical trials talking about prevention of breast cancer for people at risk, but those are really still early. And right now we're really talking about high-risk screening rather than prevention. The Elliot Breast Health Center actually has two screening resources. Mammography for women who just need a screening mammogram. They don't have a family history. They don't really have any particular risk factors. They haven't had a prior biopsy that puts them at risk. And those are people who just come in, they have the best equipment available to them, they have a mammogram, and they have it read and reported on. The second patient population that comes through here are women who are at risk. They could be at risk of breast cancer, they may be at risk of manipulation with cysts or callbacks or extra films in the past. But we try to attract women who have family histories to do their imaging in a different way. Their primary care physicians by this time are clued into the fact that we offer a screening that's very different. It's associated with physical exam, mammography, immediate film review, problem solving if it's appropriate. So somebody that comes in and there's something different on their mammogram, we try to resolve it at the time they're here, all the way to biopsy. Pathology department is used to providing us with an answer as far as tissue that we send over within 48 hours, and sometimes earlier than that. So the amount of anxiety that a woman has from the time that you raise a question till the time you resolve it is exactly the same, whether something's benign or something's malignant. And that's the philosophy that drives us to try to provide all the means possible to give somebody an answer as quickly as possible. So we do high-risk screening here in a different setting for different groups of women with family history in particular, or prior breast cancers. If we treat somebody with a breast cancer, we encourage them to come back and have their imaging done right here. The best precaution is education. Not only professional education, but also personal education. So our genetic counselors are very busy sitting down talking to people, because what some women think their risk of breast cancer is much, much lower than what their real risk of breast cancer is. So knowledge is control and knowledge is power. It varies. If someone has a mother, for example, with a breast cancer that's happened before menopause, we usually encourage them to start thinking about having their screening done around the age of 30. And it may come in different forms. MRI, for example, is a way to image denser breast tissue in younger women without radiation. So that can be a supplemental tool to standard mammography. But 30 for people who have younger people in their family with breast cancer, who have a history that makes you suspect that they may really have a chromosome defect. And people who have had a family member who's maybe older when they develop breast cancer, maybe you should start thinking about screening at 35.
The answer is no. The vast majority of women with a family member who has breast cancer do not get breast cancer, but we know their risk is higher than normal. And if you consider that the normal risk is somewhere between 8 and 12%, then having even a couple percentage points is something that's serious and you need to be carefully screened. And I think we offer a wonderful service here at the Elliot to do this kind of high-risk screening, which is not done in many places, so that you actually see your doctor the same day that you get your mammogram. And hopefully that's going to be the most important thing in finding breast cancer early and continuing to see a rise in the survival rate.